I'm Ryan Martin, physical therapist and MSK Ultrasound specialist. I am an owner of a brick and mortar company here in Phoenix, Arizona, and I also am a partner in AMSKU, which is where you're here now, which is the ultrasound. So we're glad that you're here. Enough about me. This is Colin. Give us a little bit.
Yeah, my name is Colin Rigney. I'm one of the co-founders of AMSKU and just excited to be here tonight. I really appreciate everybody's patience as we get this whole system set up. This certainly is new. It's new to us. And we wanted to do something new that was different than what you can typically find in this education space. So this evening we got some cool stuff lined up. Hopefully everybody got their checklist for the shoulder, which we're going to be covering in detail this evening. We have more than enough time to cover everything as we go and hopefully answer all your questions. So as we're going, this is going to be live and interactive. This is not something we're going to hold Q&A at the end. So Ryan is going to help moderate, but as we're going through the checklist, definitely if something comes up, a pearl, a question, anything that comes up as we're going through our process and our protocol, definitely put it in the chat. We'd love to hear from you. We have some prizes lined up, right?
Yes.
Some giveaways of some content, tools, ebooks, things that can help you that are actionable in the clinic. And really, what we're doing here is we're sharing our passion, what we really like, which is teaching education and really mainstreaming MSK ultrasound. Really it's our mission to get this modality in as many offices as possible. If you're seeing MSK patients, musculoskeletal patients with joint pain in the outpatient setting, inpatient, it doesn't matter. You should learn how to use ultrasound. And that's our mission with this company. So as we're going through all this tonight, just keep all that in mind. Thank you all for bearing with us through the technical challenges. And we'll get things going here really shortly. You got anything else you want to add?
Yeah, just so everybody knows, this is one of many. So we're going to be doing this a lot. So these are going to get better. So the camera angles, the audio, the glitches, you guys are all pioneers with us, just so you know. And another thing is, here's rules of engagement. There's no real rules. If you want to chat, bring it on. I'm going to be moderating as Colin is doing a live scan with our model here. And so if you have questions, bring them up. And so I'm going to be firing them off to Colin as you bring them up as fast as I can. If you have anything that you think is amazing or novel or whatever, give us a thumbs up. Keep it rolling. Now, what Colin was saying is there's going to be giveaways. So I'm going to be throwing some polls up on occasion, and each of these polls is going to have a time frame for you to answer. And so the certain first few 5 to 10 people are going to get free giveaways. And so when I say free giveaways, it's kind of redundant, but we're going to give you giveaways of all sorts of content. So keep your eyes peeled, keep listening. There might be some things in there that might sound a little tricky, but if you're paying attention, you guys are going to get something out of this. All right. I'm going to walk over to my station. We got Colin. He's going to add some flavor here.
Yeah. And so the reason for this setup, why we wanted to take you all through step by step is anything you do has to have a protocol to it. There's got to be a systematic way of how you go through your checkpoints. And so if you didn't get the email with the protocol, have a pen and paper right next to you and write these down. And we're also happy to email it to you after the fact this evening. But we're going to go through that checklist tonight. And I brought my model on. So come on over, Brian. This is Brian, my friend Brian. We've known each other for a good number of years now. And I know he's got a few injuries. So we're going to look at his left shoulder. But most of what you're going to see is some pretty healthy anatomy, which was very deliberately chosen because we want you guys to see what things should look like. Everything on the screen should pop at you, and you want that to be, especially if you're new, which is a good point. If you're just new to ultrasound, or if you're just like getting your feet wet or just thinking about getting into it, it's very important to understand what normal is before you just jump into pathology. And along with that, knowing what normal is, you also have to have a system of what I can fall back to, maybe if I don't have all the protocols memorized, so having something with you that allows you to have to be that roadmap as you're going through these assessments. So I hope you guys all find this valuable tonight. Like Ryan said, this is the first of a series of these we're going to be doing, and each one is going to improve the better we get at these technical things, as well as with our presentation. And your feedback matters a lot to us. So we really appreciate everybody's time. I don't take it lightly that you've all chosen this time to spend with us this evening. And I'm just going to get started. So Ryan is going to work the screen share on us. So I'm going to start the ultrasound.
All right. So hopefully all of that's working. You can see I put up a nice little checklist while he's getting this together. So you can see this is how we're going to go through. We're going to go through the biceps, short and long, subscap, short and long, infra, short, long, posterior capsule, sphenoglenoid notch, which I think is heavily missed, supraspinatus, short, long, ACJ, and dynamic stuff. So this is kind of what we're going to go through tonight. Have your checklist ready and be ready for some questions, comments, and concerns. Let's see if I got this camera rocking and rolling. You like that, everyone?
I look forward to this back and forth. So as I'm going, Ryan, I want you to hit some of and I'll cue you, but I want you to hit some of the whys behind these anatomic checkpoints.
Yeah, absolutely. So let me share my screen here. Hold on one second. Let's go to window and let's go. And so as I share this screen here, I want everybody to let me know that it came up perfectly. So
we thumbs up.
Let's see. Somebody give me a thumbs up or something. You guys know where those oh my gosh, there's like 100 thumbs that came up. That is rocking. So we're ready to go. All right, everybody, let's do this.
So we are starting with the biceps. Okay. We're starting with the biceps. And with the biceps, the reason for this being the first on the checklist is the bicep tendon in the bicipital groove is the window to the shoulder. It's been described, that's not our description. That is, I believe, John Jacobson description, because of its interarticular component with the glenohumeral joint. We're looking for fluid where there shouldn't be fluid. It's very rare to find isolate. Well, it's very rare, but it's not super common just to have isolated bicep tenosynovitis, which it certainly can exist. But the reason why we're looking at the bicep first is there fluid accumulation there? If there's fluid accumulation in the bicipital groove, that can correlate with possible rotator cuff pathology and or some glenohumeral arthritis or other issues with the glenohumeral joint. So as you notice where we're at here, patient position matters. Okay, the patient's seated, elbows by his side. We have the arm supinated, the forearm supinated, and we got the shoulder at neutral. And also notice how I'm holding the transducer. Okay, don't be afraid to get some gel on your hands. Okay, I have what I call this lumbrical grip, and I'm really getting my hypothenar. So on my pinky side, I'm getting a lot of contact on the body to allow me to better control and just have better dexterity over the transducer and be able to manipulate it. So as you watch, as I'm doing this, I'm really not moving very much. I'm just slightly toggling the transducer as I move distally. So now I'm going to track this biceps. So if you see my cursor on the screen, okay, this is the bicep tendon, the bicipital groove, this bony, this bony layer here you see, okay, laterally. So on the right side of my screen, this is the greater tuberosity. On the left side, this is the lesser tuberosity. The biceps is sitting in the middle. We have transverse ligament right over the top. And I'm going to translate the transducer inferiorly, and you're going to watch the groove start to flatten off. When the groove flattens off, I'm looking for a key structure that's going to move from left to right on my screen. That's the pectoralis major tendon. Okay, this is the pectoralis major tendon moving to its insertion on the humerus. And that's about the level that I stop tracking it, okay? Because past this point, it starts to turn into muscle. And you see right here, you're going to watch the bicep turn into muscle. We have the short head on the other side. Okay. So a couple, one particular pearl I want to talk about here is notice how, as I'm sitting squarely in this is the extra articular portion of the biceps. Um, Notice the shape of it. It's a little more homogeneous, kind of oval. And as I move upward, so I'm getting more towards the intra-articular portion of the biceps. See how it's kind of more like oblong here. This is because the biceps is traveling over the top of the humerus, moving up to the superior glenoid, and that kind of that magic angle that's described in the MRI views. And so that's the difference here. And you also see not only in the shape but also this echo texture around it. Okay, we're getting into some of the coracohumeral ligaments and glenohumeral ligament intervals, along with the rotator cuff on either side. So posteriorly is supraspinatus, more anterior or medial if you're thinking that way. This is with the subscapularis. I'm going to get more into that when I get over towards the isolated rotator cuff views. So now, whatever view you look in one, you have to look in two, because one view is no view whenever you're applying radiology to your practice here. Okay, so
Colin, real quickly, we've had some comments about your shoulders in the way a little bit. Yeah, there we go. Now we can see that whole probe. That looks perfect.
Great.
Yeah. All right, everybody see that okay? Give those wild thumbs up, everyone.
Great. So now we're long axis. And at the proximal side here, okay, so left is proximal, right is distal. And you're watching the bicep. This is the intra-articular portion. This is that magic angle I was describing. So it's going to curve up and around the head of the humerus here towards the glenoid. Okay, now we're going to move down, and you're seeing the fibers here right adjacent to the bone. This is the bicep long head in extra-articular. Okay, and so I'm just, notice how slow I'm moving also. And a couple, one particular like transducer movement you want to be mindful of here. A pitfall that we frequently see, right, Ryan, is this view where as you watch, right, the biceps is tracking kind of down inferior like this on the screen. This is anisotropy. What this is, I can see where the tendon is, but it's not coming in as nice as I'd like. The reason for that is my probe isn't directly perpendicular to the structure I want to view. And so I'm going to take the distal ends of my transducer and heel it into the patient's skin here. And now you see the structure really horizontal in the screen. So one rule I like to really emphasize, doesn't matter where you're at in the body, bone is home. No matter what structure you're looking at, bone is always your landmark. Okay. And because bone is the landmark, I want to get that bone as parallel as possible in the screen, no matter what view I'm trying to look at. And we'll get more into that when we get into some of the other structures here. But also, like I said, this doesn't apply just to the shoulder, other areas of the body as well.
Hey, Colin.
Yep.
We have a question coming in from Zach Frey. Hey, Zach, how you doing, man? Is there anything in these views might suggest an indirect sign of possibly a slap? So if anybody doesn't know slap, that's a type of labral tear. It's superior labral, anterior to posterior. So Colin, is there anything that would be an indirect sign or something that would be helpful in that diagnosis?
I think it'd be really rough. I think it'd be difficult with ultrasound alone. That's a really good question. And we get that a lot. Because ultrasound, the sound waves aren't able to penetrate bone in the way that the superior anterior labrum sits. Okay, there's too much bony block there in order for us to actually get to it. Now, you asked for indirect signs. I suppose that, in the case of some real bicep irritation, you would look for, and you're always looking for this anyways, okay, but you would look for additional, like really thickening of the tendon as it kind of transitions into the intra-articular portion. But this is a bit of a false, you got to be wary here as well because of that magic angle I talked about. This isn't a true, you're not getting like a nice true view because of the way it's curving over. So I would just be careful here not to overcall potential bicep issues on the proximal end. Most people are going to look, they're going to look like the tendon has a lot more diameter to it on the proximal side versus on the extra-articular side. In some cases, it's legitimate, and they really do, but but there's a lot of false positive potential here as well. So I hope that was somewhat helpful in answering your question. You would also look for any fluid around the bicep tendon, like I described, as well. If there's a lot of glenohumeral joint inflammation secondary to a slap tear, a lot of the times, Zach, there's potential for, again, that short axis view I'm in here with the bicipital group. You look for a hypoechoic kind of halo around the bicep tendon. So that would probably be the most pertinent indirect sign you look for with the bicep.
Perfect. Yeah, I think that's a great answer. So, hey, thanks. Hey, everyone, keep these questions going. We got some more polls coming along your way. Good. Everybody, like that last question I threw out there, that was really good. I'm surprised anybody remembered what I was actually wearing. All right. I didn't tell Colin of any of these polls. So just so you know, when you're answering these, he has no idea what everybody's saying here. All right. So let's keep rolling on this. Again, throw those questions out at us and keep your eyes peeled.
Okay, and so, and Ryan, you can also track me too. Any clinical pearls around the bicep that you were listening to, maybe I missed.
One thing that I like to do is I like to have an idea of where I'm going to be scanning from like a tip to tail type of thing. I like looking from the rotator interval, and we can explain that a little bit, down to the pec major. For me, that's kind of my window of opportunity to see whether or not that's where I'm going to see anything. So with that being said, Colin's going to show you the rotator interval, and then we can just sweep it down real quick to that pec major.
So my preference on the rotator interval is to get them in this clasp position. So this is the preferred position to look at the rotator cuff, but to go with Ryan's description here, okay, we're going to find the bicep. It's going to be medial. Bingo. Okay, so here's our rotator interval. Ryan, you want to talk us through here? So we got the bicep right in the middle. So we have a cross-sectional view of the humerus. We have the bicep in the middle. Laterally or posterior, we have this would be the supraspinatus tendon, and this is the subscapularis. And so as we're tracking now distally, the pectoralis major tendon.
Now, I know we're doing picture-in-picture, and I know that Colin's actual image camera is on the smaller view. So if anybody has questions on how he's positioning the probes, throw those out there. We're more than happy to answer those, okay?
So second on your checklist, we have the subscapularis. And in order to view the subscapularis, we have to unfold, because the subscapularis is an anterior facing rotator cuff tendon. And with the patient here in neutral, we have these bony landmarks to be mindful of that can hide the sound beat from us getting to it. So we have to position the patient correctly in order to get there. So what we're going to do is we're going to unfold that subscapularis from underneath the coracoid by externally rotating the shoulder. Now, there'll be some cases where this is not the most comfortable position for the patient, and you're going to have to go through some troubleshooting in order to get there. Oftentimes, I like to have a pillow close by where we can have them just kind of rest. But in the case of this healthy, strapping young lad here, we're going to just go with this external rotation. Okay. And I'm in long axis, okay, anterior facing. And so you see with the way the probe is aligned, I'm going to orient the probe longitudinally with the subscapularis in this position. So the coracoid is what you see right in the middle of the screen, this convex looking bone. You can just rest it there. This convex looking bone. Here, let me get that.
And just so you know, as you're going, when you get a little break, I have some questions for you. So,
and I'm going to move out laterally. That's my preference, to align myself with the subscapularis and long axis. Now, here's an alternative. Okay, because the bicep is the first thing we teach. So when we get a new student, when we have a new learner who's going to train ultrasound and wants to learn MSK ultrasound, the first thing we teach is how to find the biceps in the short axis view. And so because this becomes like a lighthouse, it's like home base in the shoulder. Another way to think about finding the subscapularis and long axis is to first find the bicipital groove and then just simply externally rotate the shoulder, and the subscapularis comes right into your view. So I'll try not to block the camera, and let me know if I'm doing that again.
No, you're doing good on the visualization. But here's the thing is, I don't want you jumping too far ahead. I got questions piling in here.
Okay, let's go.
So number one, so Brett, we're going to get to yours here in a second, but do you know the sensitivity specificity for rotator cuff tear and comparing MRI versus ultrasound?
Great question. Depends on where you look. Sensitivity, specificity, we're looking at about 90% ultrasound. And then MRI depends on the study. I think the De Jesus study from 2009 is the one I go back to. There's been more recent ones. I know I read one off of Sonocyte's website recently where they were all pretty much in the 90% range, ultrasound and MRI. So the sensitivity and specificity of ultrasounds diagnosing pathology is highly dependent on the user. And not that there's not some operator dependency with MRI, because we have a radiologist reading the other end of those. It's a lot more systematic. The machine is not dependent on the person taking the picture. It's just slide through the tube and it's automated. Versus ultrasound, it's very much dependent on the operator putting the patient through the positions, the skill and the experience of the operator. So keep all that in mind as you ask that question. I'm answering the question. So, you have anything to add to that?
Well, if you look at literature, yeah, I mean, comparatively, and if you go, I have an entire lecture on this. Is if you look at just literature, just strict literature across the board, ultrasound from a sensitivity specificity, you're looking right around like that 92 to 93%, whereas MRI falls just a little bit below, right? And a lot of that comes down to having the dynamic ability, having, that high resolution for a more superficial space. It's when you get into the MRA, so the arthrography with it, and obviously the gold standard on these are going to be, in what you see in most cases is going to be the scope, right? And so when you're comparing it to that, the ultrasound and the MRI are very, very close.
So I spent 2014 to 2020 working with an orthopedic surgeon, and I did his ultrasounds in the office, both him and I. We got to a level where we were taking patients from the clinic to the OR based on our findings with ultrasound in the office and cutting out MRIs. We got our system down pretty good. And there's two things you look for when diagnosing a rotator cuff tear. Two common things that you see are highly correlated with rotator cuff pathology are fluid in the biceps and cortical irregularities in the greater tuberosity. Ryan has a whole talk on this on we have a whole course on this on our website called Rotator Cuff Tear versus Tendinopathy, going into the detail and the data behind that. This is a great question. We could probably spend a whole Like
This is, yeah,
we made a course on it. But we could spend the whole time talking about this. But I would say, just back to my original, with a good operator, we're talking 90+% sensitivity and specificity with ultrasound.
And again, everybody, just check your Q&A, the chat line there. Obviously, we have Justin Lyons crushing it with the statistics here for MRI, MRA, and ultrasound. So check those things out. They're right in there. And before you get going, Colin, let me just get one more here real quick. Bilal, he wants to know, how did you get that rotator cuff interval to line up flat? Was that crass or modified crass?
Great question, Bilal. So I have to think myself through it, because it depends on the patient. Typically, I'll start it. I'll find them in crass. I'll find it in crass first, because I find the biceps here. But if, let's say, for instance, like I can't get them extended enough or it's too painful, okay, I will get them in shoulder neutral and slightly extended and externally rotated, because I want to be able to see the subscapularis in that view as well. Okay, so if you can see my position below, to have it as flat as possible. And this is my type A personality. That's not quite good enough for me there. There we go. Okay, so short axis on the humerus, and roughly, I just have them slightly abducted, slightly externally rotated to expose that subscapularis. But that's my usually my go-to to get it. Some patients who have the ability to get this in the crass position, you can certainly do that as well. I just haven't been able to do it as consistently in this particular view, mainly because the biceps, as you see, the biceps kind of hidden down here. We got to get them extended. And again, if they're symptomatic, right, this can be not a comfortable position to be in order to identify the cuff interval. And you see here, I'm short axis, okay, but it looks like, it doesn't look like I am, but I'm happy because of the position the patient's in, shoulder extension, some slight abduction. I'm having to really align and track my ultrasound transducer with the bone. Okay. So I go back to this position here, and I can pretty much find it consistently on every single person, no matter what their pain level, what their pathology, what their tolerance level to position is. So hope that was helpful. Do we have any other questions coming in?
No, those are good right now.
Okay. So back to the subscapularis. To find this consistently, again, my two ways to do it. For those who are just beginning, I think the best way to start is, because we teach the bicipital groove first, this is home base, this is your lighthouse. You're going to find bicipital groove, find where the biceps and short axis is. I'm going to externally rotate, and now it comes right into my view. So I didn't even move the transducer, if you noticed. All I did was I externally rotated the patient, and it comes right into your probe. Some of the pitfalls, especially with beginners, they think we have to move all over the place in order to get where you need to go. The more you learn, the more repetitions you get, you're going to find that I call it moving without moving. So you're basically leveraging the patient's ability to position, as well as your little micro movements with the transducer. So now we're in long axis subscapularis, and we unfolded it from the coracoid, which you see on the left side of the screen. So one characteristic I want to talk about is, we talk a lot in metaphors with respect to the rotator cuff in our views. So in long axis, looks like a bird's beak. Whoops. So the shape of the rotator cuff and the insertion as it tapers looks like a bird's beak. So right is distal, left is proximal. And this is our cortical surface of the lesser tuberosity. So just for reference, you see where this kind of hook comes in? and there's a bone transition here where the insertion, the tendon bone insertion really starts and stops is about right. Well, I'll put a measurement. So if you can see my measurement tool, medial to lateral, this is roughly the tendon bone footprint of where I'm looking at the lesser tuberosity and the subscapularis insertion. And from here down, this is articular margin of the humerus. And as we go this way, okay, we're heading down towards the glenoid in this view. At this point, it's I don't want to get super deep into the weeds, but it's important to talk about a little of the subscapularis anatomy. So most of your pathology, most of your subscapularis issues, you're going to find at the upper third portion of the lesser tuberosity. Okay, because this anterior facing subscapularis inserts the lesser tuberosity right like this. Okay, so there's a section of bone it attaches to that we'll just say cephalad and caudal. Okay, and it's divided into three components. You have an upper third with purely tendinous attachment. You have a middle third of the subscapularis to the lesser tuberosity, which is kind of a hybrid tendon muscle. And then the most inferior portion of the subscapularis insertion is the purely muscular attachment. So very rarely does somebody have a totally full thickness subscapularis tear. More often than not, those tears are going to happen at the upper third and are closely related to biceps pathology. Why? Because when a biceps tendon fails, that coracohumeral sling fails, okay, the coracohumeral sling helps to keep the bicep long head in his groove. Okay, so Ryan, you can stop me if I'm getting too far into the weeds or if we have questions.
We do have questions.
Yeah.
While you're going here before, and we do want to get to this scan here, but these are good questions. Besides frozen shoulder, is there anything else you're looking for at the rotator interval?
Let me get to that as we get to the supraspinatus.
Okay, I think that's a good call on that. And then here's another one. In the subscap view, and this I like this question. How can you tell the difference between subcoracoid bursitis and if there's a recess effusion there?
Really good. Okay, I like that question. So my experience, to have an isolated bursitis in the subscapularis area is pretty rare. It can happen. It's just not as common. And sometimes if there's fluid leakage from this triangle here, this is the subcoracoid recess. It can leak out into the bursa, but the fluid is coming from an articular component. And likely it's either from, a high-grade rotator cuff tear and or articular pathology that we can't quite see with the ultrasound. So is it possible to differentiate between the two? I suppose. Is it clinically relevant? I think that if you're able to clear rotator cuff pathology and you see this fluid and you don't find any high-grade pathology, I think then you can confidently say, yes, I think that fluid I saw was related to bursitis, not subcoracoid recess fluid from an articular source.
So I got another one here from Matthew Higgs. So can you just go ahead and show us the dynamic motion of subcoracoid impingement?
Beautiful. So two landmarks we want to have in our view: the coracoid, the lesser tuberosity, and then we have the subscapularis tendon. I want to point out one thing. So Doc, as you ask that question, I want you to keep in mind the structure here. This is the coracohumeral ligaments. That's part of the coracohumeral sling. So this ligament is going to track over and become part of the transverse ligament later and into the rotator interval. Okay, so you're gonna keep your eye on this area as we're moving the patient. So this is the view you're gonna want to get. So you have this V infolding here, and now we're gonna externally, internally, actually rotate the patient. So you see that ligament structure come in. It's like a lot of things with ultrasound. If you can competently dynamically assess, the anatomy becomes a lot more clear. So you're watching this bursa. This is the bursa. See, clearly there's a delineation between the tendon and the bursa, which the bursa is just a subdeltoid fascia, really. Okay, but we're looking at this area here, the quality of the gliding underneath the coracoid and that coracohumeral ligament there. Okay, but that's my assessment. Okay, now you can. There's not a whole lot more. We could get into more advanced dynamics, I suppose, but typically, if I'm looking at impingement, if I'm looking for impingement, I think that clinically there's a reason why I'm doing this. More often than not, you're gonna find what you need to find simply with this view alone. So I hope that was helpful, Doc.
Awesome. Good.
Anything else coming through?
Not right now. I have a couple questions, but they're going to be related to a couple of things that we're trying to, get into a little bit. So once we move into some of the infraspinatus and posterior caps, we'll probably have some questions for you. I want to keep it smooth. And just so we're aware, we did get a little bit of a later start because of technical issues. Thank you for sticking with us. We got quite a few people on here. I'm going to be throwing a couple more polls out. You guys have been crushing these polls so far. It's 6:48. We're just through the subscapularis. We're going to be rolling into the infraspinatus. And again, keep those questions going.
So to visualize the infraspinatus, there's a couple different ways we can position the patient. My preference, so with anything ultrasound, doesn't matter where in the body, you want to be able to best visualize, you want to put that structure on a slight stretch. So what we're going to do is we're going to place the patient in, I like to just have them grab their opposite leg. You can have them take it across their body as well. I think this puts it on a little bit better stretch because that number one, we're not impinging the shoulder here, but also these structures are coming around. So it's going to hide the supraspinatus, and everything we see in our view here, it can be nothing else but the infraspinatus. So the best way to visualize, especially if you're just learning, the best way to visualize the infraspinatus in this isolated view, I like to start in short axis and identify the acromion. So here's the acromion, and I'm just going to drop down. The first thing I run into is the infraspinatus in short axis. This can't be anything else. Okay, so as I'm here, I'm kind of like right on the border between where the muscle tendon junction is. If I come a little more inferior and posterior, you're going to see these turn into the muscle compartments, and we have infra and teres moving down. Okay, so I'm just going to find that sweet spot and really hone in on the infraspinatus. Okay, I typically don't linger on these a lot during like a real exam because when I get into the CRAS position, I'm gonna look at these again in a more dynamic way. So to keep us all in time, I'm going to transition into the long axis infraspinatus, and again, long axis. We have this bird's beak appearance. So the left is the insertion, and towards the right is the proximal end of it. And you're looking at the insertion of the infraspinatus here. So what I'm going to do now is I'm going to traverse posteriorly and identify the glenohumeral joint. So what we teach our people is because the infraspinatus is relatively easy to find. Again, thinking systems, you got to have a system to fall back on when somebody's anatomy, when you're in a tight spot, maybe there's some pressure. Okay, you have to have something to fall back on every time, and bone is your landmark. So you're gonna want to hug the bone with the transducer. So as you're watching me do this, I'm just walking the transducer posteriorly, and I'm gonna And if I'm following the humerus correctly, it's gonna walk me right to where the joint is. And if you notice, I'm just slicing the humerus just like this. Okay, I'm not dipping down this way because I think I have to. I need to just trust my landmarks. So I'm going to trust my landmarks by following the humerus on back, and it's gonna take me right to where the glenohumeral joint is. So quickly, I will just freeze and walk through the bony landmarks. So on the left side of the screen, you're seeing the humerus, and that dark line that you see this right next to it. That's the articular cartilage. It's dark because hyaline cartilage is has a high level of water content. That's why it's dark. Dark is water is dark on ultrasound. In the middle, this triangular infolding here, that's what we can see of the glenoid labrum at the posterior aspect. And on the right, this is our posterior rim of the glenoid. So I'm going to unfreeze now. And so now I'm going to coach the patient. I'm going to have you take your hand like this now. Okay, and then just keep your elbow where it is and literally just, externally rotate, internally rotate. All right, so you're watching the articulation of the humerus on the labrum. Why don't you slow it down a little bit? Sit up nice and tall. There we go. Take it down some depth. Okay. So as you're watching him internally, externally rotate, you see a couple things. You see the humerus is moving, and you see the infraspinatus contracting as he externally rotates. Okay. So what we're observing here, we're observing just quality of gliding. Okay. Do we see any atypical? Is the labrum staying in place? Is it jumping out of there? Is there fraying? Is there capsular effusions? Here's the capsule. Everything is very homogeneous with this view. And things potential things you would find are things I just mentioned. Okay, so you're looking, is the labrum stable? Is there fluid in the capsule? And are we seeing any joint space narrowing, any weird things with the humeral head, any defects, any things like that would make us potentially have our antennas up to articular issues, especially with your arthritis patients. Okay, you can take a break. So in which case, we always have MRI as a second tool to, just be able to look at the articular issues that we can't see with ultrasound. I think it's very important to have that in the back of your mind as you're doing this. Okay. But I think that there's probably a couple of people on this call who can also attest that the better you get with ultrasound, the less you rely on the MRI to tell you what kind of rotator cuff pathology is going on. You really, in our practice and in the doctors we work with, they dramatically reduce their MRI orders for cuff pathology. So just some things to think about.
Hey, Colin, real quickly. So on the infraspinatus, on that facet back there, so when you're looking at that medial facet as it kind of dips back, you usually see that little cortical irregularity. It's like a normal defect that we tend to see right near like that articular margin as you come up a little bit more anterior there. So keep going.
Like here?
Yeah, right in there. How do you know if that's a Hill sac? See how it dips down? How can you tell the difference if that's a Hill sac or if that's a normal facet space?
Well, this is only as good as your clinical brain.
That's it.
And there's usually, so if and I've been there, believe me, that's going to be in their history. Okay. They're going to have some kind of like trauma in their history. Maybe they've dislocated, maybe they've subluxed, a car accident. You're going to ask those kinds of questions. That should help guide you as you're getting into this. So I hope that's helpful. That to me, that's what I always go with. In order, so just characteristics quickly of a Hill sac lesion. Okay. So you're watching, you see this here. Okay. These are so common. It's ridiculous when you're after you scan a fair number of shoulders, you're going to see a lot of these just garden variety little, these infoldings here. This could be a little subchondral cyst. It could be a lot of things that are typically pretty benign and not clinically relevant in a lot of cases. But again, go back to your clinical, put your clinical hat on it, ask the questions: is there a history of trauma, dislocation, subluxation in this patient's history? And that will help you be able to differentiate. And now a lot of the times too with the heel sock, okay, the heel sock is going to be a lot more pronounced than this. There'll be usually some kind of step off, a big divot, like a crater within the, this where it's convex here. You're going to see a crater kind of coming through an inverted. It's going to be an inverted convex, right? It's going to be concave.
Yeah. And just real quickly, two things that I'd add real quickly is, number one, know the history. Was there a dislocation? Does that make sense, right? Clinical brain. Number two, it was pointed out here on the chat line. Don't forget, you can always check contralateral side. Yeah. So those are just a couple things that we could check there. All right, back to Colin. Sorry, okay. We have a ton of questions going in here. Do you want to just answer some? No. You know what? I like this one for later. You want one more? Okay.
No, I was going to say, how about next time we start on time?
Yeah. Hey, next time we're going to start on time. I promise.
Love all the questions, guys, truly. I want to be respectful of everybo's time and our model as well. So I'm gonna get on to, I think we have the spinal glenoid notch quickly. Okay. And then we're going to get to the rotator cuff, the supraspinatus, get into, I think, that rotator interval. We had another interval question, right?
No. We're past that one now. We're good. So we got we're going to be doing the spinal glenoid notch, and then we're going to be heading over to the supraspinatus.
Okay.
All right, everyone, we're coming in there.
So spinal glenoid notch is the inferior branch that the suprascapular nerve will come out of. Okay, so how to find the spinal glenoid notch, and why is it clinically relevant? Do I routinely scan this? No. But in cases of sorry, I'm thinking, in cases where, potentially there is a paralabral cyst, you want to be mindful of, is that cyst impinging on the suprascapular nerve at this level? That's super common. Okay, so that's really the relevancy behind being able to identify the spinal glenoid notch. Okay, so the best way to find is we get our posterior joint view, we come back on the glenoid, okay, and we're going to move just inferior slightly, and you see this notch come in. Okay, there's going to be a concavity that opens up on the scapula here, and this is the suprascapular nerve you're looking at on my cursor. Does that come through to you, Ryan?
Yeah.
Okay. So you see the relation of where the labrum is in that suprascapular notch. Okay, so clinically, they're going to come in if they don't have an MRI, right? There's this, insidious atrophy of the infraspinous fossa, and it's going to be pretty pronounced. It depends on the level they're at, but you're going to be able to compare it to the other side as well. But that's how you identify it, and the clinical relevancy behind it, as I just described. So go to the next thing. What I'm going to have Brian do, we're going to the supraspinatus. You're going to put your hand on your hip like this. So typically, the coaching here matters with your patients. Okay, we don't want people slouching. Okay, we don't want people slouching down doing this. What happens is the supraspinatus gets hidden underneath the acromion. Okay, so this is where the operator dependency portion of what MSK ultrasound comes really into play. So again, coach your patient. Patient position matters. Sit up nice and tall. What I have them do is put their hand on their hip, have you point your elbow back, and this is the position. And as far back as they can tolerate, right? Because if they're in a lot of pain, oftentimes you're going to have to be able to modify it. So I'll put them in like what we call a gunslinger position. Maybe if they can just get to their pocket there, or if they have adhesive capsulitis, almost everybody can get here. It's not pleasant, but they appreciate you taking a look there, and they're willing to hang in as you try to figure out their problems. So I'm going to go back here because this is most ideal. Okay, so the best way to find the supraspinatus is, now Ryan just did a little segment on this recently, but we're in this position, everybody's going to have this axillary kind of concavity here. I'm going to start the probe here, and I'm kind of in no man's land. Okay, I'm going to clear the bicep long head. This is the bicep long head and long axis. And I'm going to sweep posteriorly or laterally, I guess, depends on how you're thinking. I call it posterior. And the first bird's beak I run into is going to be the supraspinatus. This can't be anything else. Okay, so again, I'm going to start medial or anterior, and then sweep laterally, posterior. And the first bird's beak I run into, this is the supraspinatus. Okay, and the supraspinatus, this is where 90% of your rotator cuff issues are going to be, or 80%, whatever. The majority of your rotator cuff issues start in the supraspinatus. And if you can get really good at evaluating these, again, with a good clinical brain and a good operator with the transducer, you're going to be able to do a lot of this diagnosis at the point of care level. And as you get better at these exams, you should be able to do this in 10 minutes or less, really. And that's the utility of the ultrasound. So the things we're looking at here, and I know we're going to come up on time, so I think that I just want to point out some anatomy, and then if we have a couple questions, we'll take those, and then I'm going to do a couple dynamic views, and we'll go there. So Brian, do you have like 10 extra minutes? Okay. So I want to point out where the tendon bone interface is on the ultrasound. So you see where this greater tuberosity, the hyperechoic line of the greater tuberosity is. There's this little hook here. Okay, this is the facet of the superior facet of the greater tuberosity where that tendon attaches. What we're looking at here, roughly medial to lateral. So left is medial, right is lateral. This is the footprint width of the supraspinatus where it attaches. Okay, anything from here back downward. Okay, this is articular margin of the humerus, articular cartilage portion of the humerus. And let me go back.
We're having questions about, is that bursa normal?
For Brian, it's normal.
Okay, so there you go.
Okay, so I know this because I train with Brian. So in a lot of your active people, it's super common to see asymptomatic bursal thickening. So that's actually a really good question. So somebody was definitely had their hat on with that one. Okay, so this is where the tendon is, and then the bursal line. Then we have this bright hyperechoic line over the top. Okay, this is the superficial fascia, the subdeltoid fascia. Okay, and then you see where this bursal measurement is. So something we can do here quickly to flesh some of that out is we have our dynamic capability with ultrasound. So my preference to evaluate dynamically is I will scout passively first. So I'll kind of, sometimes I maybe have them actively assist me, but you see as I'm extending the shoulder and you watch, it's not a large amplitude movement. Okay, not low velocity, very low amplitude. I want to be able to carefully see any asymmetries or any paradoxical movement patterns that you see with high grade pathology issues. Okay, but you see what's moving and what's not. Okay, so as I'm doing this, you see the tendon moving, and the bursa is not moving over the top of it. Okay, so I'm just confirming like where the bursa ends and the tendon starts, and vice versa. So I can also move a little more proximally as well on that tendon and observe. Is the tendon bunching? Is there any disruption? Is it bone moving one way? The tendon's moving the other. Okay, is the bursa doing anything funny as I'm doing that? So those are all like, that's my initial scout as I'm doing my dynamics there. And I will linger on this for if I'm really hunting. I'll put them into a couple other maneuvers. Another one you can do if I'm really looking for something where I think it's a high grade pathology, I'm gonna elicit a contraction from the patient. So in this position, again, this is where you have to really coach them. So they're hand on the hip, sitting up nice and tall, and I'm just gonna say, okay, I'm gonna just put my hand on your elbow, okay, and I'm just gonna nudge you. Don't let me move you, okay. Hold. Don't let me move you. Hold. 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 I'm not pushing very hard. He's just kind of matching me, okay, and release. Okay. And I'll do it again. So this is exactly what I take patients through. I'll say, okay, you got the hand on the hip. I'm going to put my hand on your elbow now. So I want you to hold. Don't let me move you. Okay. So hold, nice and easy. Hold, and relax. Okay. And as I do that, right, we didn't see any fibers moving. Everything is super stable. So again, that's a healthy representation of what we see in the supraspinatus there. So now, because we're pretty anterior here, I know we've already cleared the biceps, so I know I'm just posterior to it. This is a supraspinatus. Okay, I can now translate the transducer, okay, posteriorly and get into my infraspinatus from here as well. So again, you can evaluate the supraspinatus and infraspinatus pretty really well just in this clasp position alone. Okay, so a hallmark of how do I know it's infraspinatus and not supraspinatus is you see the footprint change. Okay, so in this position here, what do I mean by that? Okay, see the hook here? Okay, this is pretty classic supraspinatus, the facet of the greater tuberosity it's on. Now, as I move more posterior, you're going to see this footprint of the greater tuberosity flatten off. And the texture of the tendon start to change. Okay, some of this is, I don't trust this as tendinopathy. You have to also remember that the infraspinatus overlaps the supraspinatus on the greater tuberosity. So what we're seeing is a little crisscrossing of the fibers as it's moving to its insertion, I believe, to like the middle and inferior facets of the greater tuberosity. And I've seen quite a few of these also in the operating room under the scope, and it all looks just convex on the greater tuberosity. So you can't really differentiate out the facets, but the fibers, and there's anatomic variance and that sort of thing, right? But for the most part, you can see the transition zone if you have a good teacher who's running the scope with you, which I really did. It was very clear to point that stuff out to me, and it translated really nicely to my training as I applied it to the ultrasound, because this is 2-dimensional tool and we're operating our 3-dimensional dynamic body, right? And that's the one thing as you're getting into ultrasound, you're first learning or you're just starting, even if you're beginner, intermediate, those are things to consider. The patient position matters. How you coach the patient matters. The cues you give matters. All those things ties into what constitutes a really good ultrasound exam. So as I'm going here, Ryan, I know we're a little bit over. Do we have any? And I didn't go into the short axis of the supraspinatus, but I did some of that with the rotator interval. Do we have anybody with some questions? Do we have any questions coming in? Anything that I'm to hit that I missed?
No, I don't think you really missed anything. I think what you got is going really, really well. One of the questions that's up in the list, there's like 88. So I'm trying to filter them right now. So we have a lot of really good questions, a lot of really good stuff going on here. One of the ones was, and if I could paraphrase, so I'm sorry out there if I didn't get it right all the way, but how does excessive adipose tissue affect placement and pressure of the transducer quality of image? Now, this is something that I go over extensively in my physics course and on our physics webinar. So that is a really good one. So I just want to give a shout to, I want to say it was Delisa that threw that one out there. So thank you for that question. I will answer that one personally for you on a phone call. But it does affect it because, again, impeding tissue changes the tissue quality. People who are larger habitus will change the overall echo texture or quality of that picture. So we'll get back into the rotator cuff, but I think it's important to note that sometimes with that adipose tissue, and if you have microvascular diseases, This will change the overall quality of the image dramatically. So we'll talk more about that one. I will forward you my webinar on physics, and we will talk more about that one. All right, sorry, Colin, let's get at it, man.
Yeah. So we'll do this and wrap up with the AC, and then we'll take another question or two and then be done. So now, okay, so we were in the long axis. Okay. And if you also look too, so the transducer and long axis is going to align kind of along the shaft of the humerus. Okay, so we have a nice long axis picture here. I'm just going to turn the probe 90 degrees. And then we're in short axis on the supraspinatus. Again, biceps is our lighthouse. So the first thing we do in a short axis view is what we want to identify where the biceps is. Okay, because anything that's directly posterior to it, we don't want to miss any potential. Most of the pathology in the supra is going to start anterior. Okay, we want to make sure we clear all of that before walking our way posteriorly. So we have the biceps down here on the left, and a couple features to point out with the supra in short axis here is this is our tire on wheel appearance. So another metaphor for how this looks in short axis versus long axis. So long axis is our bird's beak. Short axis is our tire on wheel. So we have this convex bone, convex tendon, convex bursa. Left on the screen is anterior, right is posterior. And we're in that same position, the crest position. So as we make our starting point there, we're going to now move posteriorly. That's my scanning sequence, is scan anterior to posterior. And the further back we get, I'm typically not doing any heavy investigating here. Most of your pathology in short axis, I like to, and again, this is a preference. So the more shoulders you examine, my preference is to start in long axis, then go to short. Ryan's, I think you like to start in short and then go to long. Right?
I'm a short guy. Yeah, I start in short axis. That's just kind of the way it goes. All right. Hey, Colin, real quickly, while you're scanning that, I got a question. Don't let me forget. I got to ask about calcific tendinopathy. So keep going, but don't let me forget that. I'm not forgetting you all out there.
Well, how about we do that? Because I just described this, and I know we're starting to get up against it here.
So the question comes down to, how often do you see calcific biceps tendonitis? So biceps specific, and how would that be displayed on ultrasound? So, I mean, in my opinion, I don't think I've really seen bicipital calcific tendinopathy. It could be in literature. I could pull that up for you. Oh, that is a Brett Sandy. Of course, that's a Brett Sandy question. Hey, Brett, thanks, man. Like I said, it's not something that I've seen in practice. I don't have the literature in front of me, but it would be displayed very similar to any type of calcific tendinopathy in the human body. So depending on the maturity of that calcium or that hydroxyapatite deposition, is what is it going to be displayed as? How old is it? How chronic is it? Is it dense at that point? Is it going to create an acoustic shadow? Again, these are going to be all the same characteristics that you're going to see in calcific tendinopathy almost throughout the body. So I hope that answers it for you, Brett. And then, of course, Brett's throwing more questions out here. Okay, let's keep going, and I'm going to get to your guys' questions. Let's go.
Okay. Well, anything else you want me to cover here? Because I know
I think the AC joint is the last one. And we have two questions on the AC. Can you grade an AC joint separation with ultrasound? Can you typically grade it? Or I would personally say, yeah, you can see it. I mean, that's an easier one, but how are you grading it?
I wouldn't feel great about actually putting a grade on an AC joint sprain. I'd want to correlate that with an x-ray.
Cool. And then just one real quick one before we go to the AC joint, and then we want to kind of wrap this up. I'm trying to get all your questions here. With biceps interval, are you measuring and comparing both shoulder coracohumeral ligaments? And the superior glenohumeral ligaments, if suspecting frozen shoulder, is it better to do this or look at the axillary view of the shoulder? Here's the thing. Literature is now supporting quite a bit of the axillary view. It's just a little bit more of a difficult advanced technique. The coracohumeral ligament has really high sensitivity and specificity for adhesive capsulitis. It's really easy to measure. And yes, if I suspect it and it's borderline to the measurements that we see in literature, I am always checking the other side, so the contralateral side. That's one of those things that I think clearly distinguishes MSK ultrasound versus a lot of the other modalities is when in doubt, check the other side. So great question out there. I am always measuring. In fact, every single shoulder scan that I do, I have measured the coracohumeral ligament. It's just my personal nerdiness. But if I am teetering and they don't fall into a clinical presentation, or if they do fall into a clinical presentation and I'm not quite sure, I will check the contralateral side. All right.
Okay, so AC joint. Now, Brian has actually, if you can see this beautiful scar he has, as a result of one of his physical endeavors, he has a pretty high grade AC joint sprain, or sorry, I would say it was more like it's grade 4 or 5, right?
It's a 5.
Yeah, a 5. So in a repair, subsequent repair.
I think they call that a grade obliteration.
A grade obliteration.
Basically, the only thing I had to do was pop the clavicle out of his skin. So that's
yeah.
Well, you still have time. You're young.
So they did a distal clavicle resection to give him some more space here. So this is about when was this? 2 years ago?
June of 2022.
Okay.
Yeah, so 2.5.
Okay.
Yep.
So on the left side, this is our clavicle. On the right side is the acromion, and the space in between, that's the AC joints. Okay. And then the ligament you can see coming over the top. And the question about can you grade it? In my opinion, I wouldn't feel confident actually grading this, but given again, clinical history and all that stuff you've done, you can certainly tell they've stretched it or have injured it, and have a good idea maybe in what range of a grade to probably expect if you're getting films. So that's really kind of a more nuanced, more detailed answer to that question, but hope that was helpful. Let me just go one thing on the coracohumeral measurement, and I think this one's pretty easy, pretty consistent. I like this one. Ryan was describing. So the measurement here on most people, it's usually around 3 millimeters. So we're going to take this measuring unit here, right? So 3.3 millimeters.
And if you all want that, because there are people asking for references on that, we have those. They're all loaded on. We have a massive database of literature. If anybody wants any of that stuff, I have the literature to support that as well. So this was an amazing, I mean, we have questions coming in here. I'm sending people personal messages as we go through. We try to answer as many live as possible. So I want to say thank you, Colin, for going over that. Let's give Colin a round of applause. Find that little meme button and show him some love on that. We've had a lot of people stick around on here. Brian, thanks for being a model. Everybody give him a big thumbs up as he flexes out of here. And then, so what we're going to be doing is we're going to be doing this again. We're going to be knocking out some of those technical issues. And it's just something that always comes up, but guess what? They're going to get better. Next go around. So next month, let me get this camera on my ugly face here. So next month, what we're going to be going over is we're going to be doing the elbow. So we're going to be doing this same series, unless you all send us questions about, hey, I really want to see X, Y, and Z. Then we're going to do it. So this is for you, okay? It's not just for us, right? We enjoy what we do, but this is for you. This is getting you the information that you need to be better at what you do, or to get you motivated enough to get started in this. So I want to say thank you, everybody, for sticking around on this. I'm going to have one more poll. So if you guys are sticking around, Colin, is there anything that you wanted to say?
No, I just want to thank everybody for their time. And again, technical issues, got a little late start. I appreciate everybody sticking around and donating your time with us tonight. We don't take any of that lightly. So again, thank you.
All right. Okay, everybody, we're going to be popping out of here. We want to say thank you, everyone. If you have any other questions, One other thing I just wanted to bring up, since we have a couple people that have hung tight with us this whole time, if you have any other questions, if you have any concerns, reach out to us. We'd love to hop on a discovery call with you. If you hop on a discovery call with myself or with Colin, we're going to be putting together. So I know a lot of you won some of the ebooks out there, the shoulder ebooks, the physics ebooks, things like that. But if you guys want a free ebook, we're going to have all of that. Just book a discovery call with us. Our assistant. Oh, by the way, I just want to give a huge shout out, give a bunch of round of applause for Tawiro. All these technical difficulties, she's the one that ironed everything out between her and our team. So they took care of everything. So if you want that, book a call, send us an email. We'll send those links out for you. If you want to book a call, we'll send you ebooks and references, anything that you need. So I'm signing out, everybody. I want to say thank you very much. Let me put the camera on Colin if he wants to say goodbye.
Thanks, everyone. We really appreciate it. We'll see you next month.